It gives me tremendous pleasure now to introduce Chirag Patel, whose name you've already heard as an author of that EWAS paper, that early EWAS paper, and Fenna, Sillé, who has been working really hard behind the scenes to make this program a fabulous success. So turn it over to you both.
Thank you so much. Thank you so much for being here. And what we were charged with is to present to you a proposed framework, because we had to start with something. And that's what we're going to present. And over the course of the of the symposium and the forum, we will be inquiring, gathering ideas, input, feedback, so that in the end, we come up with a framework for a roadmap towards a human exposome initiative that is collectively co-created, as I mentioned yesterday. So, Chirag, you want to take it? So, building the human exposome timeline, a short history of the exposome. This is Gary's slide, and what we really wanted to highlight here is that it started in 2005 with Christopher Wild coining the concept of exposome, and we are looking forward now in 2025 with this launch of the Human Exposome Moonshot Forum, but we want to look even further. What happens in the next 2, 10, 15 years? Where will we be in 2040? So this is what we're going to do, work towards the framework and the next steps for this human exposome, and we're going to propose the following framework.
All right, so to introduce you to this framework, of course, we encourage you to come to our sessions after to debate this framework so that we can converge on potentially new pillars or new cross-cutting themes. So we have what we call pillars, which are the main sort of themes that we'd like to discuss, and cross-cutting themes that, of course, that cut across all these pillars to dive into. The first couple are enabling technologies and use of large data sources and this elephant in the room of artificial intelligence. We also believe that a strong or a pillar is considering psychosocial, ethical, social aspects and their impact and implications of developing these new tools and technologies for measuring the exposome writ large. A central theme, as you've already heard today, is about coordination, collaboration amongst our friends and colleagues across the globe, from everyone from researchers, but patients and students as well, and developing structures, research infrastructures, and clinical infrastructures to disseminate and deploy and test these new models that we are developing together. And to those ends that we think that are cross-cutting, that we believe are cross-cutting, are the first is how do we train the next generation of professionals who are practicing and developing exposomic techniques? This could mean, of course, researchers. Many of us are researchers in the room. It could also mean our students, from everyone from our graduate students, but even as we talk about going to the limit of introducing this into a medical school curriculum. We talk about community outreach as another central theme today, a global, in the global coordination and collaboration, but extends beyond that. We can become more specific. And how do we bring this to patients? How do we translate to clinical practice?
So Chirag, how can we do this under enabling technologies?
All right, so I'm so happy to talk about this part. It's been a key focus of our group and of many of you in the group, in the room. A fun fact about myself, I have serious physics envy, so I cannot start without mentioning physicists who spoke ad nauseum about the importance of measurement. So you think about Richard Feynman, who said, a concept or idea which cannot be measured or cannot be referred to directly to experiment may or may not be useful. Okay, there's some vagaries there. In fact, if we can't measure, it need not exist in our theory. So what are our theories in environmental health sciences and toxicology? And can we bring it to the scale that we've seen in genomics? I think that our fearless leader, our director of NIEHS, gave us the analogy of genomics, which is an important one, but we should not take it to the extent that we can make it an analog, but I think we can learn a lot from it, is that one of them is that they moved on from measuring one thing at a time to many things at a time, which enhanced reproducibility, it enhanced standardization, and it made science more efficient. We'll talk about if it's predictive or not, that's another story altogether. But I think those are very key learning attributes. Of course, it was fueled by standardization to ensure that our measurements are independent of the assay or technology. I think that's a second ideal that we could live up to. And of course, we need to develop and validate technologies and rigorous methodologies to quantitate and measure the exposome, ensuring that each construct can be clearly deployed, tested, validated, and linked directly to health outcomes. So practically speaking, for example, thinking about the moonshot, or what and how to deploy sensors that we were inspired by the very beautiful quote that Roel presented us with yesterday of our interactions with the environment. How can these sensors track our environment as we progress through life? Or what are the platforms and assays to measure the tissue or blood exposome? How many exposures can we measure in a blood sample? All right, so that's technologies which can be, of course, married to artificial intelligence, or another the elephant in the room here. So we've yet to describe comprehensively, in my opinion, the environmental drivers of phenotypes at writ large. Meanwhile, AI is progressing at a breakneck pace. You know, we saw these last couple of Nobel Prizes actually awarded to AI techniques. Can these approaches, when we're married with these emerging technologies of measurement, help us discover and validate groups of exposures associated with health outcomes? But we can move beyond that. You know, so for example, we were talking about foundation models in artificial intelligence now, and how this can enhance our knowledge of biology. And when we think about models of biology, you might think, okay, we have of etiology, we have the 2-hit model for cancer. You have the insulin carbohydrate model or energy balance model that is under debate in obesity. You have the amyloid tau model in dementia. So how does the exposome and our new models inform these debates, which are still under debate and unsolved? And what are our own theories and models of environmental health? What is the environmental architecture of phenotypic response and association? And how do they, again, inform our debate about disease? But critically, how these AI approaches sort of advanced are critically thinking about what are the benchmarks and data to support these AI technologies to make them AI ready. So practically speaking, what are the near-term steps? You know, for example, how can we scale up the search for unidentified peaks in our mass spec experiments? That's one. Or even beyond that, what would it take to train a foundation model to query all possible exposure phenotype associations? So please.
Yeah, and I think we should come back to those in the breakout sessions tomorrow, and even the one today, to come up with those questions and make this framework, expand on this framework. But we also need to consider the psychosocial, the ethics, and the societal aspects and impacts. For example, what if the human exposome has the capacity of being an identifier at the level of how we can identify somebody with their fingerprint, with their retina scan? Already, with only 3 measurements or knowledge points. For example, a person with a rare disease living in an area with certain pollutions, and maybe even one more chemical exposure or a railway system very close, 200 meters or something like that, or we don't even know the geospatial pinpoint. But with those 3 coordinates, not location coordinates, but environmental exposome coordinates, we can identify a person already now with just 3. Imagine what an exposome can do if we know everything that this person in a lifetime has been exposed to. We want you to consider those questions when we put this framework together, because those implications are huge. Also, what does it mean for clinical translation? Can we use data from all these exposures into the clinic? We have IRB systems, but have they considered exposome? Can we go back in real life with these cohorts that we're going to be discussing also later and do all this? Because those consents that were taken in place in the past, did they really consider the impact of mapping and charting an exposome? We need to think about that. Also, how are we going to share data, and how is that real? How can we make sure that this data is not going to be misused? Healthcare is, as we are saying, our health is influenced by the exposome. The responding situation in that is, how is healthcare going to take into account the human exposome? Not just from the exciting perspective of a scientist, like, yay, we can do that more and we can map more, but also health insurers, healthcare providers. How is it going to affect if an exposure in a certain, your exposome, not just one exposure, but your whole exposome can predispose you in a sense to a certain health outcome? And will that affect your insurance coverage? These are things that we need to consider with ethics and AI, but also, how are we going to use exactly what was discussed in the policy panel? That we are bringing this to the community, that we are serving the needs of the community, that we are understanding what communities and populations need, both at the individual level with precision medicine and at the bigger level, at the population level. And even maybe once we grasp the human exposome at the level of planetary health. So we want you to come up with questions like that and challenge us as a group to make sure that we don't forget anything when we put this framework together. So we talked about global coordination and collaboration in the panels, and this also goes hand in hand with what infrastructure, and that's the next pillar, go together, like governance and legal frameworks. This is going to be data from across the world. We need to collaborate, but we also need to know, how are we going to take care that this data globally is integrated, shared, but also not misused, and that there is not just one level of power over it, in a sense. So it should be collective. We need to develop human resources that cross the globe, like what Dr. Otiboding was saying, not just the scientist or the policymaker, but also the citizens. Many were talking about that. So community and integrating the community at a global level. We're here not as only scientists, we're also here as policymakers, end users, patient advocacy groups. So that at the policy level and the global coordination level also, just not just collaboration in one silo, but across all silos and disciplines. We talked about data and ethics, but this is also at the global level. So research infrastructure has been mentioned, and that was another pillar that we identified as a group. And by all means, this may not be the only pillars. These are the starting points for us to start thinking about a framework. But research infrastructure is important, and that does not just mean physical locations and labs. It also means, for example, the people, and not just the scientists doing the measurements of the mass spec, but also the software engineers that make sure that we can do big data computing and all those things. And then the research application managers, the community managers, and then all the physical infrastructure around it, but also the infrastructure on how to deal with all this big data. So a lot of these pillars are also cross-sectional. So we're coming back to this slide because now we wanted to mention a bit about the cross-sectional themes. So one of the themes is training.
Absolutely. As we were discussing earlier, so the training impacts all these 5 pillars from research or graduate programs, and as we extend this to the clinic, to the bedside, how we educate our medical students. It includes, as Fenna was mentioned earlier, data scientists and software engineers for these new infrastructures and technologies. I think things like tools and data such as UK Biobank are fantastic for genetic research, but it could be that we need entire new paradigms of biobanks for exposomics research. What are those? This is an entirely new data science challenge, and research and education must change accordingly.
Yeah. And then for community outreach, which we also see as transdisciplinary, it's not just precision medicine at the individual level, but also at the precision public health level. We want to make sure that this is not just patients and individuals, but it is also at the city and at the federal policy level. We think bidirectional conversations with communities, as was indicated, is very important, but that there's also data-informed legislation. We think that, for example, knowing the human exposome and the data that comes out of it can be very useful for urban resilience or smart cities, for example. So don't just think about just the human health at the individual level. It's also at the bigger population level. Healthy aging and environmental health surveillance. For example, how can we respond to wildfires and the health impacts that it has? That is also contributing to all those major events that are happening with the weather and with wildfires, with floods, water contamination. How does that impact at the community level?
Right, and so then we talk about translation to clinical practice and applications and critical use cases that integrate across these 5 pillars as well. This is a topic near and dear to my heart. So first is that we've seen a handful of examples in genomic medicine where this idea of precision medicine has brought fruit and it actually has impacted patients at the bedside. What role does exposomics play in precision medicine? How can it make our search for targeted interventions that much more precise, for lack of a better word? Second, is enhancing our discovery processes. Oftentimes, we are stuck looking under the lamppost, what's in our questionnaire instruments, what are convenience in our epidemiological studies, by all good intentions, that's what we believe the environment is. But I think when we open ourselves up to new hypotheses, married but with these enabling technologies and large data analyses approaches, we can really search for new things that we had not anticipated before to really explain the variance in disease outcomes. And things that we hadn't thought about before. For example, my whole training, I look back, was in fact brought to bear by the genomic advances. I think it sponsored, for example, the NHGRI for this training program that ironically enabled my studies in environmental medicine. But we can see all the other economic byproducts and applications as well, such as new monitoring systems. Imagine new monitoring systems, for example, as we've seen with wastewater, or new disease surveillance systems. For example, the CDC and Haynes is remarkable for anticipating prevalence or computing prevalence of disease outcomes with a few targeted exposures. What if we had an entire exposure array to assess alongside disease prevalence?
Yeah, so these are a few questions that we're just pointing out, but you have the opportunity to present them more during the breakouts. One more thing that we wanted to point out that is part of our framework is that we are looking in increments. What can we achieve already in the next year, the next 2 years? What can we achieve in the midterm, 3 to 8 years? And what will be our long-term vision for 2040? And with that, we will leave you questions and comments can come in the breakout sessions later. We are now at an actual break. We will see you back at 11. Thank you.
Thank you.